Hi, I'm Glenn.
And I'm Brent.
And we're the Penumbra Brothers.
We focus on you.
All right, Glenn here from the Penumbra Brothers. We're going to do a quick video on the Danelius-Miller and the Clements-Nakayama hip. So when you're doing these, you're going to have an AP hip already performed, and you probably already confirmed there's a fracture. So Merrill states 40 inches. The angulation to the hip, long axis of the hip, is going to be roughly about 40 degrees. That can vary quite a bit depending on the patient's position. So you want to be about 40 degrees in relation to the long axis of the femur. So we've already got our room set up here. So we have our beam set up, our patient is here, and we have our IR here, making sure that it is perpendicular to the IR. Now Merrill's, like I said, says 40 inches. However, I'm a much more proponent of having 72 inches because you're going to have some OID. So that added SID decreases the magnification. So the only other thing we're going to have to do here is we're going to bring this leg up, and we're going to bring it way up like this. If you have help, you can have somebody hold this leg. If the patient has the ability to hold it, they can put their hands under their knee. Go ahead and do that. And he can hold his leg like that. Now, not all of our patients are going to be able to do that, but this is going to give us a really great image right here. This is a good position. If you're really strapped, you don't have somebody else around, you can actually throw an office chair without wheels right up here and rest their leg on it. Whatever you need to do to keep that leg out of the way. And make sure with us, we don't have a grid. This particular portable has a virtual grid, so we don't have to worry exactly about making sure that we are centered to the hip, although we are. We make sure, and we have done that. So go ahead and straighten your leg out. And that is the Danelius-Miller surgical hip. So the only variation to this on a Clements-Nakayama is you're going to add 15 degrees angulation to the tube. So I'm going to go ahead and do that now. Now the reason you would do this is if there's a bilateral injury and you are unable to move this leg up, or the patient is incapable one way or the other. All of your centering is the same. The only other thing you want to do is you want to angle your IR also 15 degrees. That way you're still perpendicular to your tube. And that is the Clements-Nakayama hip. So you're in the ER, OR, and you don't have a cassette holder. So one of the things you can do, you can find just about anything. A Mayo stand will work. A little file cabinet, rolling file cabinet like this will work. Just set your cassette up, or your detector, and even though it seems a little redneckish, if you just tape that on there, put your tape on there pretty firmly, and make sure you've got good tape. Like this is nylon tape, and it'll stick on there pretty good. The advantage to this, one of the real advantages to this, is you can always increase or decrease the height of the gurney. So once you get your patient set up, you get the tube angulation correct, you can just slide this up beside the patient, set your angle, you can stand behind it, make sure you're perpendicular to the central ray, and if you need to adjust the height of the bed, you can do that. Super easy way to do it, only cost you a couple strips of tape.